Let's get into it.
Okay, thank you, Tom.
So the patient is a 50-year-old female. The actual case, she had been diagnosed with this condition several years ago. So I changed it because the history was too easy.
Thanks.
So I'm gonna say she has no complaints. She's being followed up by a regular optometrist in the community. They found an abnormality in her retina and they sent her to see a retina specialist. So her medical history, she has Hashimoto's thyroiditis, and she had a mammoplasty, and she's on Synthroid and birth control. So, and someone should probably tell her.
And sometimes for depression, sometimes for, what else would you
For flashes.
no, for, PMS syndrome, or for skin. Some people use birth control for, skin disease, skin for acne.
Or menstruation, heavy menstruation.
Is it off label?
She has administration, she doesn't have a problem.
That's true, that's true.
So her vision is great, her IOP is a little bit lower than the normal. So, like, go ahead and see the fundus.
Okay, this is a fundus photo of the right eye. Media is clear. The nerve looks pretty pink and sharp. Vessels look pretty normal. Your attention's drawn to the macula where you see multiple hypopigmented, almost like cholesterol appearing, like yellow lesions, like a stippled lesions, mostly in the macula, but there are a few extending temporally and superiorly. Metric findings in the left eye, fundus photo. Oh, hello, Vishnu, welcome back.
Almost got you dodged that one.
Dodge that one. Left eye fundus photo, media clear, nerve looks pink, sharp, flat, vessels look pretty good, and then your attention is once again drawn to these yellowish deposits that in the center around the macula, and then you do have kind of like an area of hyperpigmentation in the background. I can't tell if that's just by contrast and then of course they are right in the macula and the fovea, but then they do extend a little bit, the stippling temporally and superiorly. Okay, OCT of the right eye and the left eye here, and so good foveal contour, nothing in the vitreous, but you do have subfoveally some RP, it's very small. I think it looks like RP thickening. The ELM looks good. Is the interdigitation zone maybe a little stippled as well? But that would explain the good central visual acuity that the ELM is still intact, but you see these subretinal deposits as well as thickening of the RPE Brooks complex. So here we have a fundus autofluorescence of both eyes. You see some hyperpigmentation surrounding the fovea, and then you have this like stippled hypoautofluorescence, sorry, not pigmentation. Some stippled hypoautofluorescence, more so on the left than on the right, but you kind of see it on both. And it corresponds to the lesions being a little bit more distributed on the left than they were on the right, more dense.
This is the last photo.
Is it IR?
This is IR.
Okay, IR of both eyes, and similarly that the left eye has a little bit greater pathology than the right, but you see this hypo reflectance, mostly just centered in the macula, the stippled lesions here. Okay, so this is a differential diagnosis for some yellow, almost like lipid appearing deposits or cholesterol deposits in the macula. They're symmetric but bilateral, and pretty symmetric, but more on one eye than the other, with good central visual acuity. So the differential for these yellow deposits, I mean, you always have like Coates disease, you have anything that can cause these deposits. So you always have to say like AMD or macular degeneration of sorts. it doesn't look like a vitelliform pattern, and that usually don't have deposits, but you could say like a Bester of adult foveolar. How old is she again? 54?
54.
Yeah, but it doesn't really look like the yolk sac appearance. And then there's a lot of medications like tamoxifen and other like breast cancer that can cause crystalline deposits. I'm thinking of what else. Yeah, there's pattern dystrophies that can kind of look like that, but this looks more like deposits rather than like atrophy of RPE. Am I missing something big?
No, it's good.
Okay.
Okay, I'm gonna review, when I also was reviewing the photos, we found the same thing, essentially, I just want to point out one more thing, that on this one, the OCT, on the left at the bottom picture, it looks like although there are these PEDs or Drusen centrally, I always thought, oh, I should say the top photo, more close, more out to temporally. It looked like there were a couple other minuscule PEDs, which looked like they had like a dark fluid area underneath them. So like the central ones were totally opaque, like Drusen should appear. The other ones I thought were more like a cirrus PED, or they could just be Drusen, but I figured it was notable.
Oh, and I just saw something else. What is that, like Malaysia, Lebanese or something?
I never made that diagnosis. But yeah,
Okay,
it's like a lot.
that
of
just came to
Drusen.
me as well.
Yeah.
And one, actually on the color, one of the things about the pattern, because we sometimes do get into patterns of Drusen. Like, are they like radiating linearly outward? And I don't know that these really are. What's the previous? I thought in this one, maybe they were kind of.
Active imagination.
Yeah, but I think it's just spots. Yeah, I think it's just randomly.
And to talk about my differential, because these, I agree with Kim, could be thought to be hard exudates or focal intraretinal periarteriolar transitates. After seeing the OCT, decided to make my differential more. So my differential included A and B,
There it is.
Yeah, Melody.
yeah, and then some other drusenoid dystrophies, particular groups of melody, however you say the second word. And apparently in pachychoroid diseases, you can also develop something called pachy-drusen, which
Yeah, there's, I have it in my charts, pachychoroid pigment epitheliopathy, and it's sort of like central serous without fluid. So you'll get some people that are kind of bumpy, and I do have some of those, a very thick choroid, and you can go back, I don't think this choroid's that thick, but, very thick choroid. Where are we?
Yeah, that's not that
I
bad.
guess, I can't really tell though, it's not EVI.
Definitely not the left.
So, well, it could be, but you're cut off, so you can't say it's not.
Oh, shit.
So yeah, there's pachychoroid pigment epitheliopathy.
And so in this case, patient had age-related macular degeneration. And so it was just notable that she had been diagnosed before the age of 60. Almost all cases of AMD, the incidence is after the age of 60, and really it ramps up as age goes on, really increasing, say, after the age of 80 or 90.
Right.
So in the teaching points for the case, I wanted to cover some genetic associations with AMD. So Drusen, what Drusen are is a collection of a variety of lipids, proteins, and say shed disc remnants and lipofuscin, which contributes to the macular pigment. And so these are located technically in between the inner layer of, they're within the Bruch's membrane and between the external lamina, the basal lamina of the RPE. So although they're typically like, if you just Google it, it says it's underneath the RPE, but the actual location is technically within Bruch's membrane.
Yeah, Brooks, we think of Brooks, as you always say, is that Brooks membrane, but Brooks has got both basement membranes. So I just think it was the two basement membranes with a bunch of other stuff. So you got your basement membrane, the choriocapillaris, basement membrane of the RP, and really, I mean, they're not in the choroid, so they gotta be on this side of the basement membrane of the choriocapillaris, so they're in Brooks. Yeah, it's good.
And so, and also notable for determining, say, staging of AMD, it's related to the size of drusen, the presence of any geographic atrophy in CND. So in this case, say, one landmark to look at is the diameter of the retinal veins and arteries at the disc margin, which is assumed to be around 150 microns. So 124 microns is considered a cutoff for quote unquote a large drusen. So if you have at least one large drusen, that's considered and a singular of a Drusen is one drus, D-R-U-S-E. So, one large drus is the minimum to be considered intermediate stage AMD. So I would stage this as intermediate stage in both of our eyes.
Yes, yes.
So, but anyway, so the genes associated with dry AMD, there are many, many genes. And the most important ones, as defined by the BCSC retina chapter, is the age-related maculopathy susceptibility gene, ARMS, and it's right next to a different gene called HTRA. And they frequently undergo changeovers when the chromosomes are linking with each other and unlinking. So they frequently have mismatch mutations. And the other one is complement factor H. Most of the common genes associated with dry AMD have to do with the complement pathway. Interestingly, there are 2 FDA-approved treatments for geographic atrophy, which the target of which are proteins related to the complement cascade. So those would include Syfovre, and there's another one, which I forget.
Izervay.
Izervay.
You guys use both of them?
Yeah, we use them.
But so as there are many different, say these are gene locuses, the CFH and ARMS, and there are many different known mutations of the genes, which each have their own different risk in terms of the genetic mutation. And so you can be heterozygous or homozygous. So the textbook says if you have a homozygous a risk increasing mutation in CFH, as well as in ARMS2, your risk of AMD compared to baseline will be increased 50-fold. So I thought that was pretty interesting. But so as of right now, the AAO, although you can get genetic testing for AMD, AAO says, what are you going to do with that information? Basically nothing. So they don't recommend it in clinical practice. So there's a different chapter. So that's chapter 4, and then chapter 10. As you were,
If you do 23andMe, you get it.
okay, that's interesting.
Because I think I have one or both. I'm not.
Oh, I don't want to know that.
But we talked about a couple of these unusual drusenoid dystrophies. And so I just wanted to include that the BCSC says of the drusenoid dystrophies, they define unusual drusen in this way. Only 3 different types: large colloid drusen, Maladia leventinase stay or Doyne honeycomb dystrophy, and which is different Doyne retinal disease. So, and these, although different from AMD, behave similar to AMD as they can be associated with geographic atrophy and CND. And they can usually occur between the ages of 10 and 40 or 50. So below, younger than age of 60 or even 50 would be, you'd think of these different syndromes. And there are only 2 genes that they mention in the text. That would be FEMP1, which is associated with the Maladia one. And there's a different one, TIMP3, which is also associated with AMD, but also associated with this other rare macular dystrophy, which appears similar in some ways to AMD, called Sorsby's macular dystrophy. And that is associated with early geographic atrophy.
I think it's rare, but it's commonly tested, Sorsby and TIM3, so that you have to know, even if it is super rare.
Sorsby's?
Yeah, they ask questions on it a lot.
Yeah, they call it Sorsby pseudo-inflammatory. And the other one I've seen, actually, I have a patient with late onset retinal degeneration, Lord. Yeah, and he has what they can get wet, but they also, when he presented, he actually looked a lot like this patient. He had sort of confluent ones, and then one of the eyes had an avascular membrane. And I said, as far as I know, he said he'd been tested. He was one of the original cases in the original reports. He goes, no, I have some gene. So I had to call the guy who actually, I think was the head of the National Eyes. I called his old doctor, Steve or something, Steven? I think Steven, and he remembered the case. And he's like, oh yeah, that's Lord. I was like, oh, thanks. And so I'm training him with shots now, and he's doing well. But so late onset retinal degeneration. This is so weird because this is 54, so probably in her 40s she started, and you'll see that. You'll see some people with a lot of drusen. Now, 80 to 90% of people have a drus. So it's very common to see a drus somewhere in the fundus. That's why
I had one in my 40s when I first came here.
a drus.
Discovered. Yeah. I thought I would be blind by 50.
Right.
It wasn't.
Yeah, so you can get, so drus are very common. That's why it's nice to keep in your head somewhere that's not all macular degeneration.
There was a study that was done called, it was abbreviated the CAP study. I forget what we were using. So I think some kind of laser treatment and I don't know why we're doing it anymore, but it failed to show any significant. But the photographs were people with Drusen, and they saw, it was a good demonstration, because you could see.
Oh, the variability, yeah,
Well, they come and they go.
right.
I mean, normal Drusen come and go. Some of, if you follow them over time, and you know, you're a reading center and you can spend, do all day, you could, you know, you watch a Drusen, it'll disappear, and then another one will show up.
And you can laser, there were 3 studies done on laser for Drusen, and they all showed that the laser makes the Drusen go away, but there's a risk of neovascularization, which is probably unacceptable.
Yeah, which is what you wanna do, is you wanna decrease the risk.
Yeah, so the laser spot, so it's like the cat in the
Doesn't
hat
do
comes
any
back,
good.
which I love that story, where you just trade one problem for another, you know, like the dress is stained and they put the dress in the tub and then the tub's stained and then the stain just goes everywhere, so it's a problem. I have to say, I had a patient where someone lasered his Drusen and it aggravated the heck out of me. It's somebody in Pinellas who's very aggressive. And he's this concert pianist, and he was my neighbor, and his vision was bad, but then about 5 years later, that was his better eye, like by a lot. And it always bothered me. It was like,